The following is an HDNet original presentation.
Tonight, antibiotics. Mankind's most important medicine is now losing the war against deadly disease.
Bacteria have seen dinosaurs come and they've seen them go. So we aren't going to destroy the bacterial world. We live in the bacterial world.
Doctors fear our overuse of these drugs will mean the return of diseases we once thought were cured.
I think giving any unnecessary treatment is just wrong. It's a dangerous, dangerous thing to do over the long term.
But one European country is leading the way in rethinking some of the basic foundations of modern medicine.
We have some very good examples from the Nordic countries with a clear message to the population and the doctors: you should stop using this and this antibiotics.
We'll bring you the news tonight on Dan Rather Reports. Good evening. There are few places in which we feel more vulnerable and seek more privacy than the doctor's office. Our legal system even puts doctors in the same class as spouses and members of the clergy. But tonight we're going to take our cameras into the examination room and investigate one of the most common interactions between us and our physicians. The stakes of what you will see are literally life and death. The issue is antibiotics. We've all probably taken them at some point in our lives and given it little thought. But public health professionals say our decades-long love affair with these drugs is rendering them useless. When one doesn't work, we are given another. But sometimes there may not be any more to give.
I was so sick, I asked to die. My daughter said that was the worst thing to ever hear, was just let me die.
Pam Pyers is a wife and mother of two in San Jose, California. Weekly family dinners are a tradition at the Pyers household, and tonight Pam gathered all the people she said stood by her when 3 years ago her life seemed to be slipping away.
The reason I asked all of you here is because you were my voice when I couldn't speak.
It all started when Pam decided to undergo what she was told would be a relatively simple procedure to fix a herniated disc in her back. She expected to spend only one night in the hospital recovering. Instead, she spent the next year battling to stay alive.
The shaking is so uncontrollable that my family said that the whole bed would start to move in the operating room. I just kept holding on to the side of the frame, just begging for somebody to help me. I'd go through 100 back surgeries before I would ever go through having a staph infection.
During surgery, Pam contracted one of the world's most common and potentially lethal bacterial infections, Staphylococcus aureus, otherwise known as a staph infection. Staph bacteria can spread like mildew in a damp basement in any hospital when equipment, clothing, or even hands are not washed and sterilized properly. And these days, there's no guarantee that an antibiotic will save you. Do you remember how many different antibiotics you were given before they finally found one that worked?
I went through 5, and then the 6th being the vancomycin. And then they described it as the big guns.
If you had not received that, where would you be today?
Dead.
Pretty sure then?
I'm positive.
Every year, more than 90,000 Americans die from similar infections that are resistant to antibiotics. That stunning figure is higher than the death toll from AIDS, car accidents, and prostate cancer combined.
I think we are in crisis mode because we have bacteria out there that we can't treat.
Dr. Stuart Levy is both a practicing medical doctor and a professor of molecular biology at the Tufts University School of Medicine in Boston. He is one of the world's leading experts on antibiotic resistance. Is bacteria winning the war with antibiotics?
There isn't a bacterium out there for which we don't see resistance. What I can also say is that the majority also are resistant to more than one drug. Have we lost the battle? Not yet. But if you're the patient who died with a resistant staph infection, that person will say, or his family, that shouldn't have happened. I agree.
Dr. Levy says the cause of the crisis is not in dispute. We are simply using too many antibiotics.
Antibiotics are being grossly misused. Antibiotic resistance is mounting at a speed that we cannot control. And why? Because we don't have control over antibiotic use in the country, in the world.
But how can we possibly cut down on the very drugs that keep people alive? Surprisingly, the majority of antibiotics are not prescribed in hospitals, but in the general practitioner's office.
They will be in with you shortly.
90% of all antibiotics are prescribed here, and often when they're not needed.
Good job. All right, keep climbing. Oh.
We know the routine well. We take ourselves or our child into the general practitioner's office for symptoms that have been going on for a little too long.
I think a lot of people do feel like antibiotics are the panacea. They really believe, like, to get over this cold or this horrible sore throat or this cough, you know, oh gosh, it's been going on for 3 days. If I could only get on an antibiotic, I know I'd get better, you know. That's really ingrained in our thinking. Because we just need one copy of the invitation.
Dr. Rita Maggioni-Smith is an investigator at Seattle Children's Hospital Research Institute and leads a weekly training session for resident pediatricians at this pediatric clinic in Seattle, Washington.
So if you look at that table, we're on page 2, Jenny.
They can learn a lot from her.
There's 2 different kinds of inappropriate prescribing I think you need to think about. It's always wrong when it's a viral diagnosis, right? So if any of you ever write down URI and give an antibiotic, oh, that's bad, okay? Don't do that.
She first became concerned about the overuse of antibiotics as a resident herself in the 1990s, when she realized that what she saw out in the real world didn't match what she had learned in medical school. Doctors making up treatment plans that were not based on the evidence in front of them.
In the 1990s, it was really bad. Okay, there are a couple of studies that were done that were published in the Journal of American Medical Association and JAMA that showed that if you looked at national level data, we were, prescribing antibiotics in greater than 50% of outpatient visits for most children with colds, and antibiotics do nothing for colds.
So rather than shrug her shoulders and accept what she saw as standard operating procedure, she decided to join a research program at UCLA and dedicate her time to figuring out what was really going on.
I really wanted to understand when most doctors, I felt, knew when it was right to prescribe and when it wasn't. Why were they so often doing when it wasn't indicated? So we designed a study where for each physician who we enrolled, we would enroll a sample of parents and their children who were coming in for cold symptoms. And we videotaped the visits, because to me that visit is the black box, right? It's like what actually happens there that, makes a physician end up prescribing when maybe they ought not to.
Dr. Maggioni-Smith analyzed the interactions between 76 pediatricians and more than 2,000 patients. The results became 3 landmark studies that show a complicated mix of assumptions and miscommunication that implicate all of us.
One of our main findings was that when a physician believes a parent wanted an antibiotic, they are significantly more likely to inappropriately prescribe. So even if they just have no evidence on which to base their decision from their physical exam and the history and everything, if they think that parent wants an antibiotic, they are significantly more likely to give it for a condition where it's not really appropriate.
Parents will say, well, can't we just try an antibiotic? Maybe it will help him.
Dr. Rob Roskin has been a pediatrician at this clinic in Seattle, Washington for the past 12 years.
Oh, yeah.
He was a participant in one of Dr. Maggioni-Smith's studies and has since attended her seminars on how to prescribe antibiotics more responsibly. Not an easy task in our fast-paced world where many people, he says, are just looking for that quick fix.
There. Hi, boys. How are you? They may say things like, he's been coughing all night, and we just need to get him something so he can get some sleep. We're going off to Hawaii in 2 days, and we really want him to be okay for the plane. He's got a big football game on Saturday, and it's really important for him to get there.
And then the insurance.
The mentality that an illness is an inconvenience to be fixed with a magic bullet is just part of the American way, says Dr. Maggione-Smith, and the uniquely American approach to health care.
We kind of have a very consumerist approach to medicine in this country, where there's a huge amount of concern, I think, among physicians that their patients have high levels of satisfaction, that they're doing what's called shared decision making, and making sure that the patient, who's the customer, is happy with the care that they're getting, because if they're not, they'll leave your practice and go somewhere else.
One of my partners once had a patient say to her that they wanted her to be more like a waiter and give them what they wanted.
Hello there. Hi, kids.
I think that it's much more common for us to see more of what you might characterize as subtle pressure. We have a discussion where clearly there's a little bit of an agenda going on. So a parent might say, don't you think he needs an antibiotic? Should we try an antibiotic? What if it might be bacterial? Should we give him something so it doesn't develop into pneumonia, or it doesn't develop into a more common infection?
I want to see what's going on. So you think you feel better? Well, there's a little bit.
The majority of the infections primary care doctors see are viral, upper respiratory tract infections, for which antibiotics can do nothing. And yet, a recent Seattle Children's Research Institute study shows that doctors prescribe antibiotics in nearly 60% of these cases.
I think that the reasons doctors prescribe antibiotics for colds and for viruses hasn't changed a lot over the years. It's still that same idea that maybe there's something there I'm missing. Maybe I'll do it just in case. It's probably not going to hurt. It's much easier to just give it. Everyone's happy.
And that just may be the crux of the problem. Dr. Maggione-Smith says there is a pervasive misconception in society amongst both doctors and patients that because antibiotics have fewer noticeable side effects than most other common drugs, there's no downside to prescribing them just in case.
When you get put on antibiotics frequently, say once a month, you are, at an individual level, more likely to be harboring resistant organisms in your nose and in your throat and in your whole respiratory tract. That's just biologically the way it works. The more you're exposed to antibiotics, the smarter your bugs get, and the better they get at outsmarting the antibiotics.
So, not only may an individual find it harder and harder to treat their own infections, but also, even if they are cured of a specific illness, the resistant bacteria inside them can spread into the environment and move on to the next person, who may not be able to fight them off with an antibiotic. That's why doctors like Stuart Levy call antibiotics societal drugs.
They're the only medication that comes to mind where your individual use affects the others in society. That's because you're not treating a problem of the person. You're treating the problem caused by an invader of the person, whether it's a virus, a bacterium, a fungus. And every treatment you take creates a sea of bacteria that want to live, and some of them will resist it, and then they will grow up and can move to your neighbors, to your children. So antibiotics are unique. They're not just individual drugs, they are societal drugs.
I can hear someone in the audience saying, well, how does that happen? I take it's inside me. How does that affect you or anybody else in the neighborhood?
The difference is that if you were taking a heart medication, it's only affecting your heart. There is an example, a study coming out of a dermatology unit in England, where they looked at patients taking antibiotics for acne, clearly not a threatening disease, and they found that the individuals living in the same household, the spouses, the children, were affected by the antibiotic being taken by the acne patient. How? Because the bacteria on their skin converted from being susceptible to being resistant. So you had a whole environmental change due by the individual use of the antibiotic. See that?
I can see that.
Each one of them represents 100 million bacteria. Looks like the head of a pin, that's what they are.
Dr. Levy has spent decades trying to develop antibiotics that can stay one step ahead of this resistance. A tall order when you're competing against evolution itself.
Bacteria have seen dinosaurs come and they've seen them go. So we aren't going to destroy the bacterial world. We live in the bacterial world. So what happens? Bacteria have abilities to resist antibiotics, and they can do it either by a mutation in themselves or by acquiring resistance from other neighboring bacteria. What the antibiotic does is clear the playing field, gets rid of all the bacteria for which it can kill, and leaves the space open for those that are resistant. It's like overtreating your lawn for crabgrass and ending up with dirt.
Bacteria colonies develop resistance for the same reasons. Gazelles, for example, developed great speed. The ones that could outrun predators were the ones to pass on their genes. When a colony of bacteria is bombarded with antibiotics, most die, but a few survive, and those that do pass on their resistant genes to their descendants, their millions of descendants. In the 7 decades since the discovery of antibiotics, we have yet to invent a miracle drug that can ultimately outsmart bacteria. Now, when we return, we'll give you a look at what happened to the original antibiotic miracle drug. So stay here with us.
Mass production methods, America is continually increasing its output of penicillin, the new drug that effects almost miraculous cures.
When penicillin was introduced to a mass market in the 1940s, it seemed like a miracle. Suddenly, once fatal infections could be cured within days. Some say the discovery of penicillin was the most important medical advance ever, adding several years to human life expectancy.
The whole world of peace to come.
For decades, there was a perception that antibiotics could cure anything, and so they were used for everything.
Science has won another victory over death.
But it took only a few years after penicillin's discovery for resistance to develop. And today, resistance is so high that penicillin is useless in the U.S. against nearly 50% of infections that the drug used to be able to treat just 20 years ago.
Wherever you see clear means the bacteria have been killed.
And as Dr. Levy from Tufts University Medical Center explained, this same story is beginning to play out with every single subsequent antibiotic that's come to market. You spent a great deal, if not virtually the entirety of your career, studying this. Do you get frustrated? Do you want to just sort of grab us by the lapels and say, listen, pay attention to this?
If people can realize that overuse of antibiotics, demanding them of their physician, storing them in medicine cabinets to take with or nither one pill at a time, are causes of resistance. I interviewed a woman who kept ampicillin in a little pill box throughout in her pocketbook, and any sniffle, any little thing, she'd pop an ampicillin tablet. I mean, it sounds crazy, but people would rather treat themselves with some kind of treatment than have their car be seen by anything other than a mechanic. I would think you'd take a little bit better care of yourself.
Hard. Want to start with that?
Patient demand and doctor acquiescence in a fundamentally consumer-based culture seems to be the driving force for overprescription of antibiotics, especially when they are not indicated.
So you're not going to do any drops, though, at all.
But as Dr. Maggioni-Smith explains, new evidence in her study may also be pointing to a completely new direction.
We found in our study, a parent came in saying, yes, I think my child needs an antibiotic, and they came out saying, no, I didn't get an antibiotic, but we also asked their satisfaction level with that visit, And if the doctor had communicated well, if their expectations about communication had been met, like telling them the name of their child's illness, the cause of their child's illness, what they could do to make their child feel better, if those things happened, they were significantly more satisfied. Even more satisfied than parents where that didn't happen and got an antibiotic.
Okay, well, we'll be talking.
So communication was far more important in terms of having a satisfied consumer of healthcare than making sure they walk out with something.
So, tell me what's been going on.
I just had a really bad runny nose.
Another, perhaps more serious contributor to bacterial resistance is occurring when a patient has an illness that actually warrants antibiotic treatment.
This has been going on a long time.
A month is a really
Let's
long
go see
time.
Dr. Ruskin.
And it's definitely...
Dr. Ruskin sees patients like this mother and son every day. Their interaction is a classic example of the gray zone of antibiotic use or misuse, when, according to Dr. Maggioni Smith, prescribing the wrong drug can have consequences for all of us.
There are times when antibiotics are good for things, and like strep throat, and I think this is one of those times. So, well, for sinus infections, amoxicillin's a really good one.
Amoxicillin is an example of what is called a first-line, relatively narrow-spectrum antibiotic. Narrow spectrum are antibiotics that will only work on a very specific kind of infection. Penicillin is the most classic example. Broad spectrum, on the other hand, are antibiotics that work on many different kinds of bacteria, many different kinds of infections. They also destroy bacteria that aren't necessarily part of the infection, making them much more likely to create resistance.
The other trend we're seeing that's a little scary is when antibiotics are given, we're seeing a trend towards using much more broad spectrum antibiotics rather than, narrow antibiotics that would do the job.
Let's just pull up and see what we've done before.
Sinusitis is an infection that we commonly will treat with antibiotics, even though there are a good percentage of those cases with left alone, they would go away on their own over time. But there's no reason to use a broad spectrum drug to start out. Amoxicillin works for the great majority of those infections. And if they start with something broader spectrum, I'd say it's pretty hard to defend doing that.
But doctors say they sometimes must make compromises when patients arrive with a specific antibiotic in mind.
The one that he responds the best to is the one that they're on for 5 days, and then they take five pills. What is that? It starts with a Z, I think.
The Zithromax?
Is that an option for us?
It is. Let me take a look at this.
One drug that's been scary to watch, though, is a drug called azithromycin. They call them Z-Paks. And it was a drug that was super popular when it first came out because it was once a day, it tasted good, your child only had to take it for 5 days rather than 10 days, and it got overused tremendously. And in many cases where amoxicillin would have been a perfectly good choice, azithromycin was used. And those particular drugs develop resistance much more quickly. And now today, if you ask me, would you use azithromycin to treat anything? I'd say that'd be a waste of time, okay? I'm sure that the drug company that sells that drug would not be happy to hear me say that, but, it's not very effective for most infections anymore.
In general, that's not what we use initially most of the time because it often doesn't treat sinus infections as well. But let's see where he's been. He has had that before.
When was the last time you had amoxicillin? And did it cure it? I can't remember. One of my children, amoxicillin just isn't effective.
It did, and it was in about 2008. And at that time, it did work.
Was it for what was wrong with him at that point?
Sinus.
It's up to you.
If the azithromycin worked for him, I think that's okay.
It really seems to be the medicine.
I think that's fine. We can definitely
You think so? Okay.
do that. Yeah.
Dr. Roskin told us that the patient's mother did indeed request an antibiotic before the examination. She asked for a broader spectrum treatment than Dr. Roskin originally thought best to prescribe, and he gave it to her. In this particular case, Dr. Roskin says he felt no harm would be done by accommodating her request, But it's all part of the delicate balancing act doctors play every day between treating illnesses and keeping patients happy.
Thank you, Dr. Ruskin.
Okay, hope you feel better, okay? Take all your medicine, okay?
I think giving any unnecessary treatment is just wrong. You can say, oh, well, what's the harm? There's always the chance for harm, whether that's harm at the individual level, that I'm going to create resistance within this person, so then when they really need an antibiotic, it's not going to work, or whether it's being conscious from the public health standpoint. It's a dangerous, dangerous thing to do over the long term. That's the problem. The consequences aren't immediate.
The doctor's office is not the only place where we are tempted to overtreat just to be safe. Americans are being bombarded on a daily basis with products containing antibacterial agents, soaps, dishwashing detergents, hand lotions. Say the word germ, and most of us will buy just about anything we think will offer us and our families protection. Little do we know that these products select for resistant bacteria just like antibiotics. According to the Centers for Disease Control, there are now over 700 such products available. One can even purchase a mattress or entire bathrooms and bedrooms outfitted with products containing triclosan, a common antibacterial agent. With the stakes so high and the fear of superbugs on the rise, the tragic irony is that there's no evidence that these products actually protect us any more than what the CDC recommends. Good old soap and water.
All you have to do is watch a patient infected with a resistant organism in the hospital, and that will, I think, bring home how scary the consequences are. When you run, lab tests on the bacteria that they're growing, and everyone comes up resistant. That's scary. And some people will say, oh, is that really a problem? Because can't we always just design a new antibiotic? It seems like there's always something new coming out that we can use. The amount of time it takes to, go from an idea for a new drug to it actually being out on the market is several years, in the neighborhood of 10 years before it's FDA approved for use. And the resistance we're seeing built up against antibiotics by the bacteria that cause the infections is progressing at a much quicker rate than that. So that's what's scary. Are we going to start having superbugs that it doesn't matter what we throw at them, it won't work?
You guys mean everything to me. I love all of you.
And that brings us back to Pam Pyers. Her staph infection is currently in remission, but she says she lives in constant fear that if it ever flares up again, there won't be any antibiotic to save her.
I had no choice but to be on vancomycin because it saved my life, but yet I still don't know what happens if this infection comes back.
And you need it again.
And it don't work the next time.
Coming up next, we'll take you to a country that has taken a radical approach to antibiotics with incredible results. That part of the story when we come back. Norway is renowned for its pure natural beauty, from its snow-capped peaks to its crystal clear water. And the people who live in this pristine wonderland consider themselves among the lucky few. Year after year, the United Nations has ranked Norway as the world's best place to live. Among many factors measured is their wealth, their education, and their medical system that allows them to live long, healthy lives. But what may be most remarkable about their longevity is not what they do take to stay healthy, but rather what they don't take. Antibiotics. Dr. Dag Berold heads the infectious disease unit at Oslo University Hospital and is world renowned for pioneering a new approach to antibiotic use. He literally wrote the book on antibiotic use in Norway. Found in the pockets of doctors throughout the country, its purpose is to make sure that antibiotics are used correctly and with great caution.
The little red book here, it's a kind of cookbook with guidelines for antibiotic use. If you have a urinary tract infection, a meningitis or a pneumonia, You can just read here and you can see what antibiotic you should use, and it's based on the pattern of resistance in the hospital. Och vi liksom filmar hvordan vi gör det här.
Whereas in the United States, the decision of when and how to use antibiotics is left mostly up to individual doctors with few guidelines, that is not the case in Norway.
The younger doctors and even the surgeons, they comply very good with this book. We have done some studies, and it's 95% compliance with the book.
In real-world terms, that's making a huge difference. Superbug enemy number one in most of the world is methicillin-resistant Staphylococcus aureus, an antibiotic-resistant staph infection known as MRSA. In the United States, it's an epidemic that kills nearly 20,000 people every year.
Hi.
Yet in Norway, where hospitals are much more vigilant about preventing the spread of infections, just 2 people died of the infection in 2009, and both were elderly victims who acquired the disease abroad.
There are a lot of documentation that shows that in countries where you use more antibiotics, you have much more resistance than in countries where you don't use so much antibiotics.
So Norwegians not only have the lowest rate of antibiotic-resistant infections in the world, but they also use fewer antibiotics than nearly anyone else. Doctors here boast that they use about 1/3 of the antibiotics each year as Americans do.
We don't have that many types of antibiotics in Norway. We have phenoxymethylpenicillin, we have amoxicillin.
And Norwegian pharmacies are stocked with drugs we haven't used widely for years.
Half of the antibiotic used in Norway is penicillin, the old good penicillin, because we don't have resistance. We can treat the serious infections with penicillin in Norway, and it's even very cheap.
So how have they managed to achieve a feat that seems nothing short of a miracle in most of the modern world?
We don't have any research or clues that actually we are less sick than the other people. And I think there are cultural differences here.
Dr. Morten Lindbeck has a primary care practice here in southern Norway and also heads one of the world's only research facilities dedicated to studying the use of antibiotics in primary care. He sees the usual infections, strep throat, earaches, pneumonia, but the Norwegian approach to antibiotic treatment challenges much of the conventional wisdom we find in the United States.
Hi.
Hi.
On the day we visited, Siri Wibsted came to see Dr. Lindbeck for an extreme sinus infection.
I have felt ill the last 1.5 weeks. My head is aching. I nearly can't hear. I have pain around my eyes and I'm coughing.
After a week and a half of suffering, most Americans would expect to receive antibiotics, and many doctors would oblige. But Siri received no medicine. Instead, she was told she would heal with rest and patience.
In Scandinavia, we tend to think that nature will resolve this by itself. And we should give the nature the time to resolve it, and perhaps be away from school or work another day.
I'm very satisfied, yes. I don't want to use antibiotics if I can avoid it.
Many Norwegians will not like to take drugs unless strictly necessary. That's not a kind of an official policy. That's how we were brought up.
Gunnar Simonsen oversees the Norwegian surveillance system for antimicrobial resistance. In the 1990s, doctors around the world started to raise the alarm that the era of antibiotics may be coming to an end. The Norwegians decided to take action before it was too late.
All issues of antibiotic resistance are related to 2 main driving factors. And the one is the amount of antibiotics prescribed and the kind of antibiotic prescribed. And the other main factor is infection control. And I think we have worked very hard on both those lines.
The Norwegian government immediately put into effect strict screening and surveillance procedures. Every patient with risk factors, like having spent time abroad, is screened for MRSA when they enter hospitals and nursing homes and are isolated if they test positive. In addition, every prescription written for both inpatient and outpatient care is entered into a national database. The government keeps close tabs on doctors by scrutinizing these prescriptions, as well as recording and analyzing every single infection that shows up in a hospital. But since most antibiotics are prescribed in primary care, policymakers and physicians alike knew this was the place to look to cut down on use and keep resistance low. Norway wasn't the only place that got the message.
Got a cold? Antibiotics don't fight the viruses that cause cold and flu. Fluids and plenty of rest do. Follow your doctor's advice.
This public service announcement was created by the ECDC, the European version of the U.S. Centers for Disease Control, to educate the public further about limiting use of antibiotics, especially in cases of viral infections. Most countries in Europe haven't gone much further than this PR campaign. But in Norway, doctors and patients take the message very seriously. They even refrain from using antibiotics to treat some infections that would respond to the medicine. Dr. Simonsen says that for many bacterial infections, antibiotics barely speed up the healing process.
Obviously, the flu, you have no benefit, and common cold, you have no benefit. But even a throat infection or a urinary tract infection or a sinusitis, they have questionable effect of antibiotics unless you have a particularly severe case or you have recurrent disease. So for the huge volume of antibiotics, you may have some very minor effect of maybe a half-day reduction statistically. So one should really question the use of these very precious drugs.
Despite all the progress in education, physicians here, like anywhere else, do feel pressure to prescribe at times, especially from parents who just want to know that their child will be okay, and in certain cases are too nervous or feel they've wasted their time if they leave the doctor's office without a prescription. In these cases, Norwegian pediatricians take a novel approach.
He had an ear infection where he had fever and definitely some pain, and then there was a perforation of the eardrum, and there was definitely some pus coming out. But he was generally in good condition. So we decided to wait and see for 3 days.
They're called wait-and-see prescriptions, and they're used all the time in Scandinavia. When doctors are not sure if an antibiotic is really necessary, they can give a prescription which does not become valid for 3 days. This can be very useful in cases of common infections like ear infections.
Of those patients who we are not sure needs an antibiotic and get a wait-and-see prescription, at least half of them, they get well within 3 days, and perhaps even more of them could be better without antibiotics.
Of course, serious infections, even in Norway, require antibiotics. In these cases, doctors are careful to prescribe the most targeted drugs available instead of immediately jumping to broader spectrums like Cipro or Z-Paks that can more easily lead to resistance.
You have these newer drugs which will have different properties than the original penicillin. And for the patient, that may be very suitable because it's more comfortable to take drugs a few times or shorter courses. But ecologically, that may also be a part of the problem, because then you'll have drugs which will last for longer times out in the environment and which will have an influence on many different kinds of bacteria.
In Norway, antibiotics and the resistance they breed are viewed as environmental concerns. And that's why the country is as worried about what's taking place down on the farm as what goes on in the doctor's office.
What's important from the bacterial point of view is not whether the drug was prescribed for a man or a pig. It's simply the amount of antibiotics which are kind of spread into the environment.
At most big American swine farms, the animals are given antibiotics in their feed, both as a preventative measure and to help them grow faster. In the United States, nearly 70% of the total amount of antibiotics sold in the country are given to healthy animals on industrial farms. But there is ample evidence that when animals take antibiotics daily, it can lead to the development of dangerous drug-resistant bacteria that can spread to people. So in the early 90s, Norwegians made a decision to sharply reduce antibiotic use on animal farms.
Obviously, If you use drugs for the animal herds and the human is then infected through consumption of infected meat or contaminated meat, the bacteria causing the infection in human will be resistant based on what the animal was exposed to.
On Norwegian farms, animals are given just a tiny fraction of the antibiotics that are used by farmers in other European countries, let alone in the United States. Granted, the livestock industry here is small, but Norway's farmed fish industry, on the other hand, is one of the largest in the world. And here they have proven that it's possible to raise millions of fish at a time without antibiotics.
These are what we in Norway call a rainbow trout. It's a crossbreeding with a Danish trout and a salmon from the Pacific.
Here in the great fjord on the west coast of Norway, Anders Petersen is the director and co-founder of Fjordlaks, one of Norway's biggest fish producers. Established in 1973, the farm stopped using all antibiotics 20 years ago, one of a number of changes which has allowed for an astonishing transformation.
Today, there's no dead fish in the fish farms. It's very healthy, it's very clean. Earlier we had to take up a lot of dead fish, but today it's history.
You may be shocked to see how much antibiotics those dead fish had been fed. In this documentary from 1988, a veterinarian says fish farmers were dumping into the ocean enough antibiotics to medicate thousands of people at a time.
Veiet opp en liten dose av dette stoffet som tilsvarer en behandlingskur for et menneske. I denne dunken så det nok legemiddel til ca. 3.500 mennesker.
Og det leverte dere da til fiskeoppdrett?
Det gikk på en uke til fiskeoppdrett.
Hva syns du om dette her?
Økologisk så synes jeg det veldig betenkelig, for man vet jo veldig lite om hva det man egentlig foretar seg.
Thanks in part to reports like this, Norwegian fish farmers themselves felt an urgency to reduce antibiotic consumption. Between the years 1994 and 2008, they decreased antibiotic use by an incredible 97%. And still, during that same period, fish production increased tenfold. They were able to nearly eliminate fish diseases by using newly developed vaccines in place of antibiotics. Now, all fish on the farms are vaccinated.
We have no sickness anymore because we vaccinate all the fish, and the vaccine has been better and better for every year.
It's all part of the action plan that Norwegians say has kept them at the forefront of the fight against drug-resistant bacteria. Dr. Morten Lindback says many of the lessons here can and must be applied around the world. And it's not too late. Something can be done.
This is not a fast-going train which is running faster and faster and nothing can stop it, because that's not true. I have a lot of American colleagues who are very eager to try to change the use in the US more towards the Northern European style.
As increases in foreign travel bring all of us closer together, the threat from the spread of superbugs is very real. When we return, more of our discussion with Dr. Stuart Levy of Tufts University School of Medicine about the future of antibiotics and what keeps him up at night. Welcome back. As we've heard tonight, Americans are dying every day from bacterial infections with no cure. And there are, to quote the Commissioner of the Food and Drug Administration, distressingly few new antibiotics coming to market to address this crisis. Consider this statistic. From 2003 to 2007, the FDA approved only 5 new antibiotics. Over a 4-year period 2 decades earlier, 16 new antibiotics came to market. Dr. Stuart Levy of Tufts University says many of the large pharmaceutical companies are no longer even in the business of trying to discover these life-saving drugs. Why are so few new antibiotics coming to market?
The economics doesn't make it.
For the big pharmaceutical companies.
Making the development of a new antibiotic will certainly bring a revenue into the company, but nowhere near the revenue comes from a cholesterol-lowering agent or a heart ailment or a kidney medicine, which you're going to be taking for the rest of your life.
Just say nothing of Viagra.
And saying nothing about, the so-called pleasure drugs.
So if I'm the head of a big pharmaceutical firm, I say, look, the money is in these other things. The big money for us, the big profit for us and our shareholders, it's in this, it's not in antibiotics.
Correct. And I think the frustration and lack of understanding is if there is a real need, and everyone will say this is an area of need, why aren't the companies just jumping in and finding it? It's difficult, not as easy it was, and the return is not there. So how do we deal with that? The Alliance for Proven Use of Antibiotics, the Infectious Disease Society of America, other groups are asking the government to give incentives to large pharma and say, we'll extend your patent life, come back in. We'll reduce the taxes, we'll do this, we'll do that, come back in.
To get them to prioritize.
Prioritize and say, we may not be a lipid-lowering agent, but it's worth it to us now to develop new antibiotics.
Is there any new superbug out there like MRSA that you're worried about?
Yes, and these are not just one, but a group in the same family that are able to resist all the common antibiotics, including the penicillins. They also have enzymes that destroy penicillins and the related cephalosporins so that you're at limit to what you can treat. So we're going back to using a drug that is 50 years old, that is somewhat toxic, colistin, which is life-saving in its situation, but resistance is mounting to it. So we have a real problem.
Are we, in the main, as a general proposition, an island in this problem of resistance to antibiotics, or is it international? Is it truly a global problem?
It is probably the most important global problem, secondary only maybe to AIDS, but it's a challenge there. The World Health Organization has named it one of the 3 most important public health problems facing the world.
And they are?
They would be AIDS, tuberculosis, and antibiotic resistance. So we are part of a global problem, and we need a global solution. Bacteria move. 1 million people cross national boundaries every day. They're carrying bacteria. Yeah. I always come back to the fact that we can always do more, we should do more. And I hear patients who have lost limbs because of a toxigenic staph infection. I see patients dying, hear from that. It shouldn't be in this country, Dan. It should not be. We should have the resources, the knowledge, the ability to make new antibiotics, improve our use of antibiotics, improve our surveillance of antibiotics, help with new diagnostics. Okay, it's a lot. But what it is, it's not just for infectious diseases, but it's also for success in cancer, for success in transplants, because infections complicate those new technologies.
Well, that leads to the question, what is it going to take to at least start curbing resistance and saving lives? What's it going to take?
First, we have to know what the resistance is, in which organisms, in which part of the country. We have to fund and support a national surveillance system on antibiotic resistance. It doesn't exist. Why have we dropped the ball? Because I don't think they've been seen. Everyone says they're life-saving, they're miracle drugs. But then give them more attention, especially when people who are in the field and those are reciting this all the time. This is a big, huge problem.
Doctor, thank you. And that's our report for tonight. From New York, for HDNet, Dan Rather reporting. Good night. If you would like to add your name to an email list for information on upcoming programs, or if you would just like to send a question or comment, please email us at viewer@hd.net.